So without further ado, then I'll introduce our speaker for today, who I am really delighted is taking time out of his busy schedule to join us. Dr. Zachary Berger is an internist, a clinical epidemiologist, and a bioethicist. His clinical, educational, and research work is located at the intersection of shared decision-making, patient-centered care, and evidence-based medicine. How to make sense of a sharing patient-physician relationship in the context of social and political inequities is a central question that underlies much of our health system's imperfections. And Dr. Berger uses interdisciplinary techniques to explore possible answers, especially among what he describes as vulnerable and victimized populations. Dr. Berger is associate professor in the Johns Hopkins Division of General Internal Medicine and a core faculty member at the Johns Hopkins Berman Institute of Bioethics, with a joint appointment in the Johns Hopkins Bloomberg School of Public Health. With an active practice in primary care internal medicine at Johns Hopkins, Dr. Berger focuses his clinical, educational, and research work, as well as his widely read publications for the lay public, on the ways in which shared decision-making in the doctor-patient encounter might be in conflict with medical evidence and the political, social, and psychological realities of the patient. Dr. Berger teaches residents in their internal medicine clinic and medical students on the wards of Johns Hopkins Hospital, and is part of a Berman faculty team which teaches bioethics to residents in a number of Johns Hopkins specialty programs. He is also a staff physician at the Esperanza Clinic Health Center, which is a free clinic serving undocumented Spanish-speaking immigrants. Dr. Berger is also the author of 2 books for the lay public on doctor-patient communication and on patient preference in the context of medical evidence. He is here today to talk to us about what I think is a really critically important topic that requires our attention right now, long COVID and an alternative model of health in the United States. Dr. Berger, I'm going to turn it over to you at this point, and thank you so much for joining us today.
Thank you so much for that kind introduction. Just want to make sure everyone can see my slides. Yes?
Perfect.
Great. So thank you for that kind of introduction on the part of the director and to all the staff and for this invitation. I'm going to talk about long COVID and remaking healthcare in the US. And I should say at the outset that I'm an ethicist among the many hats I wear. And much of this talk will be not descriptive, but prescriptive, not empirical in parts, but also normative, what we should do. And so I'm going to start by talking about what sorts of change we should implement and how. And so I'd like to confront right on the elephant in the room, or maybe introduce the elephant in the room. And that is, when one thinks about history and previous attempts at change, one tends to think that that is, as someone said about history, one damn thing after another. And so, and what should be our view of change? And to introduce that general concept, which we'll come to again and again throughout this talk, I'm going to talk about one cliche that has to do with COVID and long COVID. And because we're all sophisticated individuals, it's a cliche in French: plus ça change, plus c'est la même chose, which means the more things change, the more they stay the same, which, relevantly enough, was coined by somebody in the wake of revolution, and in his historical moment, and by some historians classified as a failed revolution. So the gentleman on the right with the wonderful hairstyle is Alphonse Karr, who was a French satirist, journalist, novelist, who was most active in the 1850s, 60s, 70s. And the phrase plus ça change, plus c'est la même chose is actually said by a character in one of his novels called The Guêpes, which means in my execrable French, well, it means in French, which I'm pronouncing execrably, the wasps. Not white Anglo-Saxon Protestants, but the things that bite. And the discussion is about what happens to France and how France can get back to how France can be made great again. And Carr was writing this in the wake of maybe the first major wave of modern era revolutions, the revolutions of 1848, which swept across Europe. Now, of course, it's complicated to compare the historical moment to the present day, and what was radical then might not be radical now, but it's important to note that there were changes afoot in France that were thought impossible, and that in large measure failed, but in some measure succeeded, or at least served as examples for future generations. Among them were things we talk about today, worker power, universal suffrage, the conflict between the nation state and various ethnicities. And to realize that Carr was expressing a sentiment that many of us might express when we consider large-scale change. It's just going to fail. But I think change is possible, and we need to consider what sorts of change we've encountered in the past, where they've succeeded and where they've failed, and what lessons we could learn. And why do I mention change and systemic change with regard to long COVID? Well, there are ways of expressing why long COVID has been such a dismal failure with regard to our US healthcare system. I'm actually not going to emphasize the epidemiologic or pathophysiologic aspects of long COVID. Those things many of you know about. There have been a number of recent articles talking about the symptomatology of those that have post-acute long COVID. All of you might know that long COVID itself, the term, is a patient support group coined term. It comes from patients and really reflecting the post-acute nature of symptoms and the fact that they last some length of time. And long, I think, in long COVID implies, it may be only by implication, not explicitly, but a kind of indefinite nature of these symptoms. And indeed, in some patients, we don't know how long these symptoms last or when or if they will get better. I don't need to cite for you the number of people that have long COVID because it's still unclear. Regarding the etiology of long COVID, I will tip my hat to as a topic later. But I will say there are a couple of ways intellectually to understand why long COVID is such a catastrophe, especially in the US. And I'm going to contrast these ways, and you'll see why I favor one of them, again, normatively. One of these ways is a intellectual approach of great prestige and distinction, that is a disparities lens. Not to use a formal definition, but to colloquially refer to it as a kind of difference, where one group is different in an important way from another group. And there's much sophistication in disparity analyses. And the kind of disparities that are researched are very important. And disparities as a topic and as a topic of research is predominantly, I'm going to say, a linear phenomenon or a multiplicative phenomenon, not a cyclical or circular or intersecting phenomenon. Whereas another term, again, that I obviously have not coined, but is very prominently and widely used during this pandemic, has been syndemic, which refers to the interaction between multiple social and economic and health-related inequities that exist and how they interact one with another in the context of a given historical, social, and political moment. So you'll see, I think, why I prefer the term syndemic rather than thinking about disparities, because we're really thinking about historical phenomena that repeat, and we're thinking about long COVID not as something that's a discontinuity, but rather something that is a continuous with previous phenomena of inequity in the US healthcare system. So long COVID is different, but it's also very similar to other chronic conditions. Anyone who's interacted with the healthcare system, whether clinician or patient or caregiver or in another role, knows that there are so many chronic conditions and it's so difficult to have them, and there are so many cracks through which one can fall. Whether those kinds of chronic conditions are chronic pain of a number of sorts, whether you call it fibromyalgia, whether the condition you're suffering from or your loved one is suffering from is chronic fatigue, ME/CFS. There are many kinds of chronic conditions that people suffer from. So what does long COVID have in common with these other chronic conditions? And I submit that long COVID will be another chronic condition, it is already a chronic condition. Well, the first is epistemic injustice. And as you all know, that means, again, colloquially, that certain kinds of knowledge are taken to be relevant by those in power, often clinicians, often healthcare systems, often administrators, and certain kinds of knowledge, most often certain sorts of patients, the knowledge provided by certain sorts of patients is held not to be as reliable or important enough. Many people with chronic conditions have experienced this feeling that you know what's going on and you try to tell somebody, but no one's listening. The second point here is something that we've already seen in a lot of the lay press regarding to long COVID. There's been a lot of attention paid, and I think understandably, and to a certain extent legitimately, to the question, what causes long COVID? What is it? Is it a overreaction of the immune system? Is it a virologic phenomena? Is it an inflammatory condition? Is it symptomatology due to end-stage organ damage after this illness? The fact that we've seen, to my mind, multiple articles in the lay press, and certainly in the peer-reviewed press, about what these etiologies might be, and comparatively less attention, and certainly comparatively fewer resources devoted to what people are going through, is, I think, something that other chronic conditions have in common too. Some of these chronic conditions' very names and reference are derived from attempts to focus on the etiology. I'll ask you to consider the name fibromyalgia, and that refers to one hypothesis on one of the etiologies of chronic pain. The next point, which helps long COVID, which helps situate long COVID and chronic conditions in the same ballpark, is that in the ways in which people who are socially and communally embedded are disengaged. That is to say, they're disengaged from their social embeddedness. They're considered, and I realize I misworded on this slide. My apologies. But they, as individuals, are not considered as embedded in the social context, which helps affect their symptoms. All these things are appropriate to compare long COVID and chronic conditions, and they have a lot in common in this regard. So, is long COVID at bottom just another chronic condition? I mean, obviously the way I'm phrasing it, it's begging the question, and you guys all realize that it's actually something different. But what's different about long COVID? I'm not saying long COVID is unique in the annals of history. I'm saying long COVID, compared to the other chronic conditions that exist now, has something different about it. What is that? Well, it's a social catastrophe with individual symptomatology. Each individual's expression of the, broadly speaking, pathophysiology of long COVID is different, but it's embedded in a social catastrophe which many people around the world share. And that makes it a chronic condition that's a sequela of a acute catastrophe. And I think there have probably existed historical phenomena like this before, but this might make long COVID somewhat different from other chronic conditions. And it also helps us understand what sorts of change might be desirable or possible. So what do we do when we've got crisis, which is a social catastrophe that affects individuals differently? How do we enact change? So the word at the top of the slide, I guess part of my subtext of this presentation is I love other languages and I also pronounce them poorly. So the Greek word at the top left is drases, which means action. It's a plural, actions, I guess. So this is from taken from an article which talks about a social phenomenon that is prominent in Greece, has been prominent for the past decade or a decade and a half, and I'm going to refer to a couple times during this talk. And that is the phenomenon that in the context of austerity and the public sector being absent from the field in many areas of huge import, like health, the public themselves, the people themselves have stepped in and enacted alternatives alternative spaces of civic engagement. And to quote this article, instances of alternative organizing during which new assemblages of solidarity and resistance can emerge. So what we're considering today is kinds of action that can embody new forms of resistance to the status quo. And again, I will emphasize that this is a normative claim I'm making, that the status quo is inadequate. I'm happy to discuss in the Q&A or in general and to make that case, but I feel like there's plenty of room to make that case. So what we're talking about, besides my complete joy and astonishment that this GIF actually works, is revolution, right? And there are many ways to describe or define that word, but massive societal change is undergoing, I think, and will be undergoing. And the question is, what kind of change should be enacted? How do we socially restructure to improve health? Or rather, how do we redefine health to better society? And obviously, this is not a topic I've discovered. This is something, the definition of what health is and what it means to live a healthy life goes back to the very earliest philosophers. So again, normatively, what do I think, what would be a good direction for us to turn to, given the failures of our capitalist neoliberal status quo? There's a great book by Nonini Smith called Healing the Body Politic, which regards popular health experimentation forms, that is, new structures of providing health in El Salvador in the wake of collapse and civil war. And what would it mean for a healthcare system to be socialist, to be based on sharing in the concept of society, in the context of society? Well, it would involve emphasizing social causes of disease. It would emphasize priority given the formation of participatory organizations. And these first 2 points are actually not controversial, right? In our status quo, we talk about those all the time, right? Social determinants of health is a thing, it's a popular thing, it's an oft referred to thing. Formation of participatory organizations, certainly also a thing, an oft referred to and encouraged thing. But I think the third point here is key and maybe makes this kind of view of healthcare systems and relatively unique, and maybe is one of the main points of this talk, that social restructuring should involve empowerment of local people to take control, and they're existing in tension with, or maybe in opposition to, professionalized national planning that I and many people, many of you viewing this talk, have been participating in. So what would that mean? How can this work? Why would it fail? Why does it matter? This is all around the term solidarity, right? But what does solidarity actually mean in a practical sense? So again, this is another paper about these social clinics, about these clinics in Greece, founded in an atmosphere of austerity after the crash of 2008, during which the healthcare system in large measure in Greece, and experts on Greece might have to correct me, but from my reading, it appears that much of the healthcare system in Greece after 2008 has been based on, as in the US in certain ways, employed people, the link between employment and healthcare. And so for those that don't have a job, for those whose employers don't provide healthcare, there's a gaping hole in the public sector into which people rush in where the government fears to tread. So we're not talking about socialist revolution in the sense of burning barricades of auto tires in the street. And we're not talking about explicit mobilization. We're talking about addressing urgent human needs alongside or alternatives to state-based social support. And this is, again, it's over against, or it's compared to, instances of collaborative work that you are all familiar with from our healthcare system, NGOs, nonprofits, which also provide extra state services. These are professionalized, and there are differences in these NGOs and nonprofits between paid staff and volunteers. But solidarity initiatives, at least according to this paper, and I think this is a worthwhile rubric, reject even the classification of volunteerism because everybody is volunteering. Everybody is a solidarian. So this is a key slide. And I'm going to go through it a little bit slowly because it represents examples of healthcare solidarity in the post-war era, mostly in the US, although there's one non-US example on this slide. So I'm going to introduce briefly each reference here on this slide. And there's, I think, a lot to be said. There might be a book to be written. There might be lots of ways to go into detail about each of these examples and how solidarity worked or didn't work. I'm not going to go into huge detail, but I'm going to give them as examples and what I think is a hypothesis generating exercise and initial observations about what solidarity might mean in healthcare and should mean. The top right photo is what I was referring to before. It's an example. It's not actually not a clinic. It's a what's called a social pharmacy in Greece, part of the loose network of solidarity-driven healthcare services that I've mentioned a couple times. Going to the top left of this slide is an example or a newspaper ad from the Jane Collective, which, given the fate of reproductive healthcare in this country, might be not just a historical footnote, but of crucial relevance. For those that don't know, the Jane Collective was a group of women who provided abortion in a time when it was not legally allowed in a widespread way, but only a few states. In only a few states was it legal. And the Jane Collective started in Chicago when it was not legal. I'll say the Jane Collective, and this is important to some points I'm going to make later, was a mix of failure and success. Initially started off working with physicians who provide the services that the women who organize it themselves did not know how to provide. They worked with one physician who had a problem with license and was eventually, I believe, jailed. And then what happened was the members of the Jane Collective did a really solidarity-driven thing. They learned how to do those procedures, and they performed thousands of abortions. And at the end of the existence of the Jane Collective, they were on trial, and their trial was basically put on hold because Roe v. Wade happened. So it's a fascinating mix of struggle with, collaboration with, dependence on the specialized healthcare system and working alongside it or instead of it. Another example I'm going to go into some detail on is the middle bottom image. You folks might know about the Black Panther Party established a number of healthcare clinics in the 60s and 70s as part of their Black-led, Black separatist solidarity effort. Now, these clinics were very successful. Some of them became and still exist now as federally qualified health centers. But the Black Panthers and their clinics, as the clinics the clinic system of the Black Panthers ended with the Black Panthers. And why did the Black Panthers end? What was the historical force that led to? Well, I think it's a combination of factors. There was certainly dissension, internal wranglings, violence in the organization, and there was also an active effort on the part of the US government to dismantle such organizations through COINTELPRO, led by the FBI. So again, an example of how a solidarity-driven healthcare system working outside a state-run healthcare system can partially become part of it later in history and partially become opposed to and be defeated by it. Some other examples I'm going to talk about. The Common Ground Health Clinic, that's the top center image, is a clinic founded in the wake of Katrina. Again, in a similar circumstance where the public sector was absent from the field regarding health needs. And it has existed since that time, and part of it becoming as well an FQHC. A Charles B. Wang Community Health Center was founded in Chinatown and is now also an FQHC. The South Central Foundation is a very interesting organization where the patients are termed patient shareholders. It serves native populations in Alaska. The bottom two right images, the bottom right image is from the ODA. That's a group of clinics, mostly in Brooklyn, affiliated with the ultra-Orthodox Jewish sector. This is of interest to me because the providers, the clinicians in that clinic, many of them hail from that ultra-Orthodox sector, while the ODA clinics serve a broad range of people, not just ultra-Orthodox Jews, also African Americans, Chinese, other populations. It is interesting that this community-founded clinic is run also by those that it originally catered to. And I'm going to talk about the Muslim Community Clinic, the MCC in Montgomery County, in a bit. So I've briefly explored a number of examples. I haven't really gone into huge detail on each of them, comparing and contrasting. But I think a couple of things you might have picked up from the brief descriptions that I've given. So there's one huge preliminary observation or conflict or tension or question. What's the relationship between solidarity on the one hand, community solidarity, which is based theoretically on a level hierarchy? In a solidarity rubric, people are on a level, right? I'm not better than you. I'm not more expert than you. We're all trying to help each other in our needs. What's the relationship between that and the benefits and the needs for biomedical and technical expertise? So one observation that's been made frequently with regard to these Greek clinics and the Greek phenomenon of austerity is that these clinics, these solidarity-based clinics, can only exist because the public sector is absent. Yet at the same time, they make possible the action of that system. The public sector, the government-run health sector can rely on these solidarity clinics and vice versa. The other observation that I like to make is a lot of these solidarity-based health clinics convert to federally qualified health centers. So when a solidarity-based health clinic based on the founding of and the actions of community members becomes an FQHC, what kind of thing is that? Is that a success because you're achieving a measure of stability, you're becoming part of a wider network, you're getting support? Or is it a capitulation because rather than existing outside of the status quo, which has failed, rather than existing outside a status quo which privileges the rich and gives the shaft to the poor, you're working with that status quo? Well, which is it? I would say, and this is probably obvious, that it's both. FQHCs are kind of not the flip side, maybe the Dorian Gray, or maybe a kind of photo negative of what solidarity-based healthcare system might look like. FQHCs are some of the best things around in our status quo. I'm a big believer in them, even though one of the health clinics where I work, Esperanza Center Health Clinic, is not an FQHC. We in Baltimore who do primary care in a large measure rely on FQHCs because they serve the function that I've just mentioned, like being there where the government fears to tread. But what are the problems of FQHCs? Right? Why are they so precarious? Well, because FQHCs, the funding depends a large part on Medicaid. And from the graph on the right, you see that the increase in Medicaid funding really depends on who's in power and who and what cases are made for Medicaid, what cases are made for the government spending money on poor people. And we know it's not just Greece, right? Austerity as an element in the US political landscape, as a moral a priori, has been present since at least Reagan, perhaps a bit before Reagan. The idea that there's something wrong with spending this money, and it has to be justified with every succeeding administration. Whether the example is in the Trump administration, Medicaid waivers for states, whether it's required cost sharing, which I believe was in the Clinton administration, austerity and FQHCs have always gone together. Well, what's another issue where the FQHCs really, by their example, show us what's missing in our current status quo and where solidarity would need to fill in or might serve as an alternative? Well, the whole idea of FQHCs is that, as you see in the center image there, FQHC governing boards, I'm quoting from this paper, Who Governs Federally Qualified Health Centers, they're required to have a consumer majority and the technical and professional expertise required for effective governance. Well, what does that mean, right? The whole point of the solidarity that I've been mentioning is that you want people to have charge of their own health care because they're not getting what they need from the status quo. Well, what actually happens is this study was a mixed method study, but one of the things they did was interview people who are on the boards of FQHCs. And there's a quote on the right from a gentleman in Maryland, basically saying that, well, our board are full-time health working professionals with private health insurance, but our patients are low-income people of color. So there's a big gulf between people on the board and the people the FQHC is actually supposed to serve. Now, this is an exaggerated quote because some FQHCs do have representation, but the questions here are very difficult and deep about what it means to represent people fairly and why is it that FQHCs are by and large not represented by or governed by the people they serve. So yet another kind of preliminary observation I'm going to make is what are things that can happen to these successful solidarity clinics if they don't continue doing what they're doing, if they become co-opted. Well, what does that mean? And here's an article from the Journal of the Islamic Medical Association about the Muslim Community Clinic in Montgomery County, Maryland, which talks about what happened to it. It was founded by literally the Muslim community in the Muslim Community Center, which also I think doubled as a mosque. Maybe I'm wrong. But basically in this community center, the clinic was opened because the people in the community were finding difficulty getting care. Well, this is an article that talks about what the future of this MCC is going to be. And it doesn't have a large endowment. It depends on grants. It depends on government grants. There's going to be budget cuts. So I'm going to quote the last sentence here. The success of the clinic depends on meeting future challenges to sustain growth and viability. A continuous source of funding has to be developed. So again, this is where with all the success of a community clinic becoming part of the government structure, it also falls victim to the same logics of precarity and austerity that the government deals in. So, I've tried to present solidarity-based healthcare as an alternative to our status quo by talking about some previous examples, talking about the difficulties that meet these examples. What are some barriers in getting to this sort of arrangement? Well, obviously, part of it is that there needs to be solidarity, and we don't have that. As a physician, I can testify to the fact that physicians do not express solidarity with other healthcare workers. We like to think, special, right? As a healthcare worker, I know that healthcare workers and patients do not obviously share solidarity, do not work in solidarity. And I think in our particular political moment, there's a tension between diversity and identity and solidarity, which I think is parallel to the question or intersects with the question of which should be addressed first, race inequity or class inequity. But solidarity means working with people that are different from you while recognizing their own interests. So I think what I'm asking is, I'm the bluebird of happiness, I guess. What's the next pandemic going to look like? Because there will be one. and there will be another crisis, and there will be calls for austerity because this is the US political culture. And we need to construct solidarity to meet that need, just like we need to construct it to meet this need. And it's up to us as individuals working together, not necessarily our pre-existing institutions, although those can serve a real service, they can bring a real service. But solidarity is enacted at the level of individuals recognizing common humanity. This is a picture of migrant clothing in the border of Matamoros with Mexico. And so solidarity, I think, means crossing borders and recognizing the illegitimacy of many borders, recognize the artificial nature of many borders. And just as immigrant healthcare has had to be taken care of in a large extent outside our status quo healthcare system through models of solidarity, this image represents the kind of border crossing we need to enact. So I invite you to maybe reconsider in this light the phrase plus ça change. Maybe even as things change, maybe they won't stay the same, or maybe the thing that might stay the same is a recognition of our solidarity and what we can achieve. So I'm going to end my presentation with thank yous to my professional homes, the Division of General Internal Medicine at Johns Hopkins, to the Berman Institute of Bioethics. I'm really lucky to see patients not just at Johns Hopkins in the outpatient center, but in the Esperanza Center Health Clinic, which is as was already introduced to you, a community center for undocumented immigrants in Baltimore. And my time there is supported by Catholic Charities and by Johns Hopkins. That's half of what I do clinically. I thank my supportive spouse and children, my current collaborators, and my patients that I see and families. And I want to thank you for your attention. And I very much look forward to your questions. And I'm just going to go back to the very beginning and share my email. In case you don't get a chance to ask your questions today, please reach out to me by Twitter or email. Thank you very much. I'll stop sharing. Oops. Sorry, I did something wrong.
Thank you so much, Dr. Berger, for that really, really thought-provoking, wonderful talk. So let me just remind folks to please put your questions, ask your questions using the Q&A function. And if you want to clarify or follow up on a question you asked, then please do that in the Q&A function. We'll be monitoring and trying to make sure that we make those connections between questions so that you can ask your follow-ups as well. There will be an evaluation that we would really dearly love for you to fill out. It really helps to inform our programming at the center. The link will pop up in your web browser after the event. You'll also receive a post-event email with information about that. Again, for the biomedical engineering students or the health profession students who want IPE credit, if you can email the center at our main email address, we'll try to help you get credit. And the recording of this event will be posted as soon as humanly possible and archived on our site so that it can be continued to be used as a resource for folks. There are a couple of questions in the Q&A now. The first is from someone who says, as one of the early member-owned and member-governed health plans, that is to say group health, 1957, over time it's become much larger and much more corporate. Could your model help to decentralize such an organization and move more power and control to local communities?
I think it could. I think it's, I have to be very transparent. A lot of this, I tend to be interdisciplinary, which means I have to keep learning new things all the time. And sometimes I have to admit that there's vast bodies of literature I don't know about. So there's a lot of literature out there about power analyses and how one understands about changing organizations from within and without, um, using organizational techniques. So where a organization is full of vested interest and has power, there has to be both an inside strategy and an outside strategy. And many organizations have active strategies to dissuade inside change, right? I think about union organizations at various institutions, right, that are dissuaded. So yes, I guess the short answer is sure, that could be done, right? Decentralization could be done, and it requires good organization and good analysis of where the power lies and what would be in the interest of those who have that to cede some of it.
So the next question, the audience member says it's not so much a question, but an expression of gratitude to you for your message. The person says, I'm a retired RN now volunteering at an FQHC as a COVID vaccinator. You have inspired me, validated to some extent, but also challenged me to think about how I will behave in the next pandemic. And it is really wonderful to hear that sort of expression of gratitude. I'm wondering if you can sort of expand on the idea about using this as a way to prepare for the next pandemic. It's a lessons learned. We've been doing a lot of lessons learned, reflecting now. Not that we're through by any stretch of the imagination this pandemic, and still clearly really needing to deal with all the challenges that are posed by long COVID and meeting the needs of those patients. But I'm wondering if you could talk a little bit about, moving forward.
Yeah.
Yeah.
Sure. Well, first, I want to thank the RN and the COVID vaccinator, and who thank you for the gratitude and thank you for all your work. So one thing that I think everybody has noticed in this pandemic is that there have been a lot of groups that have sprouted up, maybe pre-existing, but some of them newly created, many of them calling themselves or fashioned after the concept of mutual aid. And I'm involved with a couple of them in Baltimore, where I live, but I think these are often promising starts, but what is absent in some of them is two things. One is a connection to the community organizations that already exist. There have been, I'll talk about Baltimore, which I know well. There have been solidarity, Black-led solidarity organizations working to serve people ignored by the healthcare system here in Baltimore for decades, right? And are these mutual aid organizations here working with them? Are these mutual aid organizations truly mutual? That is, if I help you, how are you going to help me? And how are we working together? So these are questions that I think people are asking about these groups that exist during this pandemic. And for there to be true solidarity and co-creation, those questions need to be answered. The other question I think that needs to be answered is the core tension I'm pointing to, which is, and this is something that I'm philosophically, this talk was not about anarchism, but it's something the anarchist philosophers have pointed to. What do you do with specialist care that really requires top-down, has been provided with top-down organization, right? You don't do a communal stent. There are people that are expert in putting in stents. And so what do you do about that kind of care? How do you communally organize that? So those are two big questions that I think need to be worked on now.
Well, the next question is about the sort of distinction that we often hear people talking about between healthcare as a right and healthcare as a privilege. And the person wants to know if you could reflect on how that connects or fits in with your comments about solidarity.
Yeah, I think it's a good question. Healthcare, I think, as a right implies an obligation, and so who enforces that obligation. And so one avenue is the legal avenue, just as various international organizations count healthcare among their enumerated rights, and the U.S. Constitution does not. And famously, the only group that is guaranteed some measure of healthcare on the part of the Supreme Court are the incarcerated, although they're only guaranteed a minimum level. So one legal avenue would be to say we need to enshrine that, right, in law. I think there's a limit to how far that can go. And our legal system is also constrained by the same capitalist logics as our healthcare system. So calling healthcare not a right, but a basic need, as other, ethicists have done, I think is where I tend to more. It's a basic need of human life. We need to guarantee that human life. And we're not going to be able to rely on the legal structures to make that happen. Again, we need to operate on multiple fronts, right? We need ACA, we need single payer, right? We need a bunch of stuff. But if we're talking about a priorities and where we should focus on first, personally, I think as a fundamental need is something that I would call it first.
So the next question fits really well with one of the last things you just said about, single payer. The question is, would Medicare for all be a step in the right direction in the kind of path you're describing in your answer to the last question?
So I think Medicare for all is a step in the right direction, but it's not a solidarity or communal effort. It would be a huge and salutary change to our current system, but still based largely on the same structures, right? Medicare for all is based on there being tertiary care hospitals and everybody getting, improved access. So the very model of access, I think, is a unidirectional model, right? Access means you go to where they're going to give you care, not that you're participating in the structures of your own care. And I think that's necessary, right? I think we should have free care point of service, right? All those good things, right? We should be giving, and as a clinician, right, I get impatient with my own idealism. I'd much rather my patients get their meds for free than like talk communal healthcare with them. But we have to recognize the Medicare for all, no, it wouldn't fix a lot of inequities. Yeah, I think that's sort of an obvious truth.
So the next question says, how do solidarity-based healthcare systems help address the unique health needs faced by people who experience long COVID or other post-viral chronic illnesses? Other chronic illnesses in general, I guess. Questioner says, it seems to her one of the main reasons for this population with chronic illness faces difficulty with mainstream medicine is because mainstream medicine is so focused on curative actions in a way that excludes caring for those with incurable chronic illness. Are solidarity organizations able to unsubscribe from the focus on curing illness and shift to helping those populations manage their conditions?
What a great question. I mean, it's sort of like yes. I mean, the short answer is yes. I mean, I think this is what communal healthcare should be good at if it's done right, is understand that people are embedded in their social context, and that the focus needs not to be on curative etiologies and curative care when a cure is not very likely to exist, but in supporting people in symptomatic management, in providing an environment that can support the person, not be at odds with the person. It's at the specialist care where things fall down, where it might fall down for these organizations. I'm not saying that long COVID can't be helped by specialty care. There's a lot of specialty care that can be very useful. But I think in what you're talking about, this is what solidarity-driven organizations should be good at. Now, there are many potential barriers. I'm not making light of those, but I think ideologically that would be my answer.
So I'm wondering if you could, given what you were just describing in terms of sort of that contrast between, the focus on the curative versus the focus on sort of management of the chronic conditions, if we could sort of, if I could sort of prompt you to move a little bit sort of outside of just delivery of healthcare to thinking about more broadly about public health, and invite you to reflect a little bit more on that distinction that you made at the outset of your talk between sort of a disparities lens on these issues and a syndemics lens. Just to maybe to some extent clarify that for folks, but then also to talk about sort of how this all fits into maybe public health measures to address those that interconnected web, the systemic sort of social and environmental issues that give rise to these conditions in the first place.
Yeah. So I think in understanding a syndemic, one way in which solidarity would act would be to take a very broad and very broad picture of health as its ambit, and would really require a massive redistribution of resources, which would impact many sectors of life, and would have to be driven by a communal sense of where those resources would go and how. And that would require, and this is why my model I think is socialist and not anarchist. I think we need true democratization of our structures. We need true representation of people to whom these resources have not flowed, and that goes for health, it goes for work, it goes for recreation, it goes for the built environment, it goes for transportation, it goes for everything. So I guess two things to say there. One is the resources need to be redistributed, and there has to be democratic structures, and that requires an organization of people into these democratic structures. So it's a huge project, and that's why I think local organization is the key. You're not going to get the Senate more representative tomorrow, but you're going to get your neighborhood more representative in the lifespan, or less than the lifespan of a human being, right? So I think that's not a full answer to your very good question, but that's maybe a start.
Well, I think that I work on issues in public health ethics, and it's interesting to me. The answer that you just gave sort of keys to me, sort of connects to me with some of the sort of ideas or emphasis that you get in certain aspects of the public health code of ethics. And, the idea about democratization, requiring community input, having a commitment to caring for those who are most vulnerable and meeting their needs, et cetera. But I think part of what's interesting here is this idea about, I think there's a sort of parallel analysis to be given in terms of the one that you gave for sort of clinical healthcare systems. That is to say, and I'm sort of spitballing on my feet here, but but it is to say, is that when we think about democratization and outreach and so on, is that really just about, for example, health departments reaching into communities and connecting to trusted messengers and, bringing in mobile vaccine clinics? or is there something more about a shift in power? And I think that what you're describing is, really much more a sort of shift in a shift in power, a much more egalitarian approach.
I think that's right. And I think part of the issue that medicine, public health, epidemiology actually have to face is that, as arms of the state, they have this uncomfortable straddling between public facing, but at the same time coercive structures, right? So, just thinking about a very topical, or the always topical theme of vaccines and what public health has seen fit to do with vaccines, and the fact that people are quite ready to take a coercive and punitive mode to vaccine distribution indicates that there's this tension, right? Between, does being a public health worker mean working with the people, or does it mean making sure you get the people to do the right thing? So I think it's a shift in power is certainly what I'm envisioning.
And it seems striking to me that you're talking about, and kind of not surprising given what we know about disparities or syndemics, but the fairly broad based, right? I mean, when you were just describing kind of the aspects of life that would need to be taken into account, you were thinking about jobs and transportation and recreation, green space for exercise, all that sort of stuff, education, all connects, right? I mean, we know in COVID that has all connected to people's ability to stay healthy, or to avoid poor outcomes if they did become infected. And we know that there are disparities in terms of who got sick, who had to be hospitalized, who died. We really expect, I know, those disparities to be reflected in long COVID, but it raises the sort of breadth of the social and environmental conditions of health that you have to be taking into account, raises questions all the time in discussions that I am in about sort of the scope of healthcare and the scope of public health. Sort of, what are my responsibilities as a public health professional? What are my responsibilities? What is the scope of my responsibilities as I'm not a clinician, but if I were as a clinician, right? Can you speak to that? Sort of how our idea about sort of the traditional scope of healthcare, or the traditional scope of the work of public health, relates to what you're describing in terms of?
Yeah, of course. And one example comes immediately to mind when you were talking about various aspects of the environment and the relation to long COVID. Maybe this helps also better answer the previous question, or one of the previous questions. One example that comes to mind is reading about what's happened in New York City, where many of the well-heeled fled, or I don't want to say fled in a blameworthy way, right? They went where they would be more comfortable and they would get better, more feel safer for themselves or their loved ones, as many people would do, and presumably left their real estate. And the other thing we know about COVID is that many of those who worked in essential professions, the most risky professions, were also in the most crowded housing settings, together with those that were most at risk of falling ill. Right. At the same, and those many of those people, right, were at risk of getting evicted. And I could speak to my experience of my patients in Baltimore, many of whom were either evicted or homeless or temporary homeless or living in abandoned housing and hoping the bank wouldn't find out. So the connection of these two phenomena, right? The rich are able to migrate and the poor are crammed in, and we're not letting those people either stay in their housing for free or giving them better housing. All these are actions which our public health establishment has not really weighed in on. They've weighed in on a lot of stuff about COVID risk mitigation, right? I remember I was approached by for a project a while ago, a good project, right? How do you convince Latinx in Baltimore to wash their hands more, right? Well, so that's a that's a very sort of a behaviorist kind of project, not a bad thing, a good thing, but well, how do you wash your hands regularly if you have if you have one or maybe fewer than one working bathroom, right, in an apartment where 8 to 10 people are living? So it's these questions that the academy should be here for, right? Public health should be here for establishing these countercultures, these alternative endeavors.
Right. I mean, yes, there is legitimacy to the message about washing your hands more, but if you're
Right.
not actually able to do that because the infrastructure doesn't exist in your community, or because there's too much crowding, you have to share too much, whatever.
Right.
Those sort of personal responsibility messages don't really address the fundamental issues.
Or here's another example, right? So the idea that there's an ethical question about whether you can implement a vaccine lottery. That is a lottery, not a lottery where you get a vaccine, a lottery where you get rewarded by a cash prize if you get vaccinated, right? Yep. Which I think, from a normal human being surfing the internet, yeah, my response is, yeah, that's cool, right? That's fun. From an ethical perspective, it's certainly permissible. From a priori ethical perspective, as people working together here that we would all like to build better systems, the idea that we're going to give people money to get them to get vaccinated rather than giving them money so they can live and providing them a vaccination is an easy thing because it's part of the necessities of life. I find that mind-blowing, right? Like we're getting pressed to and rewarding by, encomia, these governors that are implementing vaccination rewards, right? It's very much the epitome of I'm not insulting behavioral economics or behavioral psychology. These are important tools in the system we have.
Yeah.
But it's not an ethical a priori.
Yeah, we you may know we're in the middle of our governor has just announced some incentives for vaccination, and so there's a very active public conversation about those sorts of incentives now. Yeah. And in this state, it's not $1 million lottery. It's if the next, I think it's 100,000 people who get vaccinated will get free tickets to the fair or free access to state parks or those kinds of things. I have heard health equity advocates say, how about we give people gift certificates to the grocery store or, funding that they can use to pay their rent or something that more addresses the needs of people who are in greatest need.
Yeah, I mean, I'm not against gaming and entertainment, right? These are important things. But it's more what we choose to gamify and why we gamify it, right?
Yeah. Yeah. One more question just popped into the Q&A. So this is one of our affiliate faculty members who asks, in addition to incarcerated persons in the U.S., enrolled tribal members of American Indian and Alaska Native communities are also guaranteed health care by treaty. While the medical care in many of these indigenous communities is provided by the Indian Health Service, in 638 tribal health clinics, medical care is provided by providers who are employed by the tribal government. how are these two models of care provision consistent or inconsistent with solidarity? That's a great question.
Yeah, and obviously, given my error in what I just said, right, I can't claim huge expertise in discussing the native health system in the U.S. But so thank you for that correction. I do know that the Alaskan healthcare clinic I mentioned is an instance of this solidarity-driven health system for native populations, and I think there's the same tension there between communal health care and the need for specialist care. And I think there's also a tension there between representation within native populations, within native communities. Again, I'm not an expert in that, but knowing that, that I'll take a community that I know by example, which is, I can't speak to native communities, so I don't know them, but I'll take it. And maybe this sounds like a cop out, but whatever. So I'm pretty well read about and know a number of members in the ultra-Orthodox community in Brooklyn. And there's a lot of successful community-driven solidarity organizations. They're good at that. But representation and accountability is a real problem because it's an unelected structure. And so I would guess that that's an issue in any solidarity type system. Representation, accountability, democratization, right? Just decentralization doesn't make for democratization automatically.
Yeah.
And especially decentralization to an under-resourced system, which I know the IHS is. So.
Yeah, one of the webinars that we did earlier in this series the speaker was Mary Owen, who heads the Center for American Indian and Minority Health in out of the med school in Duluth, the University of Minnesota Duluth. And it was a really beautiful talk about, excellent talk about the state of healthcare in the Indian Health Service, and how under-resourced it is and how much mythology there is about it. So for folks who are really interested in learning more about that, that talk is archived to the Center for Bioethics website, and I would really encourage you to go because it was a really, for a lot of people, I think, a very eye-opening, and it was a really excellent talk. So I'm not seeing any more questions in the Q&A, and we are pretty much at time. So I want to just take this opportunity to thank you again for this has just been a really thought-provoking, excellent talk, and this one's going to stick with me for a while. I know gives us a lot to sort of ruminate over, and I just really appreciate your taking time out of your busy schedule to come and share your expertise with us. Let me remind.
Well, it's been a real honor.
Pardon?
Oh, sorry. It's been a real honor and pleasure, and I really thank everyone for their questions and attention. It's been wonderful.
There have been some great questions. I see there's one more comment has popped into the Q&A from someone who says, thank you. As a disabled philosophy PhD student with long COVID, the person appreciates your work. So that's wonderful to see that kind of message. And I wish that person well. So let me remind folks, once you leave the webinar today, a link to the evaluation will pop up in your browser. You'll also get it in a follow-up email from the center. So if you could please take a few moments and fill out your evaluation. We take your input very seriously at the center as we do ongoing planning. I see AVP Porta has put into the comment, great webinar. So thank you everybody for your feedback, and thank you, Dr. Berger, for your time. And I hope everyone has a wonderful Memorial Day weekend and a safe and healthy summer, and we will be back with you in the fall for another round of ethics grant rounds. Thanks, everybody.